Okay, members, we will come back from recess, and we broke right as we were finishing testimony for Representative Gruenhagen's bill. So just to refresh members' memories, we are on House File 1560.
Thank you.
And I believe we were done with testimony, but I'll just make sure. Is there anyone else in the audience who wants to testify for or against House File 1560? Okay, not seeing any. Members, questions? Any concerns? Okay, not seeing any. Representative Gruenhagen, two-year bill.
Just a couple comments is the letter from the MMA and the Hospital Association, I do want to meet with them. I have been talking with them some, and then I've got some responses back. So between now and civil law, I'm hoping to bring a relative peace in the valley to the some of their concerns. Thank you, committee members.
All right, thank you, Representative Gruenhagen, appreciate it. So members, with that, I will renew my motion that House File 1560 be recommended to be re-referred to the Committee on Health and Human, be re-referred to the Committee on Civil Law. All those in favor, say aye.
Aye.
Those opposed, no. No. The motion prevails. Thank you, Representative Gruenhagen.
Thank you.
Members, next we will take up House File 2772, Representative Dean. And Representative Dean moves that House File 2772 be recommended to be re-referred to the Committee on Health and Human Services Finance. Representative Dean, two-year bill.
Thank you, Madam Chair and members. House File 2772 has no amendments, is before you. This legislation is in response to a letter from CMS inviting states to apply for 1115 waiver for substance use disorder. The bill directs the Commissioner of DHS to seek a federal waiver and present an update to the legislature on February 1st, 2017. Many of you have heard of this issue from your IMDs who have reached out to us about their funding issues that they have. I would imagine, I think I've talked to almost everybody on this committee about that as well. I'll let Commissioner Higgins speak in greater detail about the mechanics of the waiver and about some of the specific effects on IMDs.
Welcome to the committee. If you could introduce yourself and proceed.
Thank you, Madam Chair. My name is Linda Higgins. I'm a Hennepin County Commissioner. This legislation, as Representative Dean said, directs the Department of Human Services to apply for a federal Medicaid waiver to better serve our citizens who have substance abuse disorders. And let me just say, this waiver would not affect other disability services. A waiver of the IMD bed limit is necessary because IMD limits Medicaid to pay for services only in settings of 16 beds or less. Hennepin County has about 1,400 clients every month with substance use disorders who now frequent Hennepin County Medical Center's emergency department. With this waiver, we can treat them instead in another setting that could address treatment and housing and employment and other social service needs. This waiver can save Medicaid funds that are now paying for that really expensive emergency department services. You may know there are about 60 treatment facilities across Minnesota, including 16 in Hennepin County, who have lost their Medicaid funding because of this IMD limitation. This bill will improve our services by creating a unified plan to treat this disease as the chronic condition that it is. It will leverage federal funding against current state-only appropriations, such as the Chemical Dependency Revolving Fund, and it will allow Medicaid to finance services like housing and employment for some clients. This legislation will help us better serve many clients with substance abuse disorders. It will create better outcomes and end the revolving door for some clients, and I urge your passage of it. Thank you.
Thank you. Is there anyone else in the audience who wants to testify for or against the bill? Not seeing any members. Questions? Okay, thank you so much for being here. I appreciate it. Representative Dean, any final word on your bill?
Just that the bill don't cost nothing, and will bring some federal money, and I appreciate your support.
Okay, Representative Dean renews his motion that House File 2772 be recommended to be re-referred to the Committee on Health and Human Services Finance. All those in favor, say aye. Aye. Those opposed, no. The motion prevails. Thank you, Representative Dean. Members, our last bill up of the night is Representative Baker, House File 3026. And Representative Baker moves that House File 3026 be recommended to be re-referred to the Committee on Health and Human Services Finance. We have the bill in front of us. I don't see any amendments, so Representative Baker, to your bill.
Thank you, Madam Chair and members. What we have here is touched on a little bit with Representative Dean's bill. Last fall, DHS reclassified 37 chemical dependency providers as IMDs. This is a big deal because our facilities out there that are helping folks with chemical dependency have been paying a formula that is kind of complex, but we need to do a new formula plan if the bills are going to be changed and the way they pay these are going to be changed quite a bit. And this is the issue. So we need to make sure that this bill kind of corrects that. It takes the pressure off the counties. We need to make sure that the folks in the county that are referring folks to where they need to get the best help for chemical dependency are not being swayed by funding elements and formulas. So with me today, Madam Chair, I've got some testifiers much smarter than I am that'll help explain this bill, but it's an important one, and I appreciate that tonight. Thank you.
Welcome to the committee. If you could introduce yourself and proceed.
Madam Chair, members, my name is Lane Elmer. I'm the CEO of New Beginnings. We're a treatment center in Waverly, Minnesota. I'm also on the Board of Governors of March, our trade association, and been working closely with other providers and MATAD on this issue for the last few months. So Minnesota's long been recognized as a national leader in chemical dependency treatment, and that's been founded upon the creation of the Consolidated Chemical Dependency Treatment Fund in 1988, often referred to as the fund. And it's done a really good job of taking disparate funding sources from the federal, county, and state levels and streamlining the overall process for counties and social workers and providers to work together to get clients into placement when they need it. And as DHS showed in 2013, the fund's been a good economic benefit to the state because this patient population, their overall medical expenses have been reduced, crime has been down, and their overall employment has risen. So as Representative Baker referenced before, we're here today because in November, 37 additional programs were identified as IMDs by DHS. And this goes, the definition of an IMD is any facility over 16 beds that serves a patient population that 50% or greater have a mental illness. And this issue goes all the way back to 1965 when the original Medicaid and Medicare laws were created. And at that time, IMDs were state psychiatric hospitals, which were very controversial, very costly at the time, and the federal government did not want to be subsidizing those. So unfortunately, this definition has evolved over time and has included chemical dependency treatment programs, even though they are nothing like state psychiatric hospitals. And this is well known at the federal level that this is an incongruence, and there are multiple things being done at the federal level to try and change this, but we all know how long that takes, and sometimes it doesn't work at all. So in the meantime, Minnesota is being impacted. And what we're trying to do with this bill, which Tim will explain in some detail, is clean up some of the confusing funding mechanisms within the fund to be able to have counties not be placed with financial burdens to be referring to IMDs and have them be referring purely based off of clinical diagnosis and clinical need.
Thank you, Madam Chair. Members, my name is Tim Walsh. I'm a Vice President with Minnesota Adult and Teen Challenge, and I'm also a member of March and the Minnesota Association of Treatment Directors. And I think actually the Department of Human Services have stated the goals here very clearly, which is whether a facility is an IMD or a non-IMD should not affect clients' access, Minnesotans' access to treatment, nor should it affect the guarantee of public funding for those who qualify for public funding. And that's really what this bill does. Appreciate DHS's providing technical support on this bill. It does a few things. First of all, it codifies it. It makes it clear that IMD status should not be the basis for whether counties, tribes, and health plans make a placement in a facility. It really should be based upon their clinical needs, their treatment needs, and their diagnosis. It makes an even playing field between non-IMDs and IMDs. It sets it at 15%, whether an IMD or a non-IMD. Otherwise, those costs rise for counties up to 50% for most clients. And also, it provides a guarantee that the Department of Human Services will be providing that funding for people who qualify and who need that level of treatment. Provides that guarantee regardless of the status of whether a facility is an IMD or non-IMD. It doesn't fix all the problems, and it's just an interim or a bridge solution until the federal solutions are found through the waiver, which this dovetails very nicely with that. But it does buy us some time until then. You know about the overall problem with the epidemic of alcohol addiction, chemical addiction, opioid abuse, and so on. And of course, this provides the funding and both the access for that. So we agree with DHS that the IMD classification should not affect Minnesotans' access to our public funding for residential chemical dependency treatment and co-occurring treatment, I have to add, based on the earlier bill, and we just urge your support for this bill. Thank you.
Thank you. And thank you to both testifiers for being here. Really appreciate it. Is there anyone else in the audience who wants to testify for or against the bill? Not seeing anyone. Members, any questions? Representative Liebling.
Thank you, Madam Chair. So when it says in the bill, the commissioner shall not deny reimbursement, so does that mean then that the state funds would be used to pay the whole cost? Because I'm not sure exactly how this works. Or does it just mean that the reimbursement that wouldn't be denied is what the state would have paid if it was not an IMD? So if we were getting the federal share.
Yeah.
Mr. Walsh.
Madam Chair and Representative, what we didn't want to go to is in the details of the Consolidated Treatment Fund, but it is based upon a formula, as Representative Big was talking about, which is an 85% share for the state and a 15% share for counties. And that's been the historical basis for paying for residential treatment, and it maintains that 85% share for the state and 15% for the counties. And it doesn't discriminate against IMDs and doesn't jack that rate up to 22.95% as a result. So that's the formula.
Representative Liebling.
So, Madam Chair, so is this, so is there a cost to the bill?
Mr. Walsh. And Representative Liebling, I will say too, we do have Matt Burdick from DHS who could also help explain the funding if
Okay,
that would.
and Madam
be
Chair,
helpful.
was this going to finance?
Yes.
Oh, okay.
Yes, it is going to finance next.
Do you
Oh.
want to answer that, Brad? Or do you want me to answer it? Okay. So,
Mr. Walsh.
Thank you, Madam Chair. And Representative, is there a cost? My understanding from the Department of Human Services, and Brian Zervis is here, Deputy Director over our policy division, they have developed a fiscal note, but it's going through the MMB, and then after it goes through MMB, that's when it'll go to the finance committees, and then there'll be discussions about then how will, within the overall budget, then how would that cost be addressed?
Representative Liebling, would you like to hear from the department
Yeah, I think
also?
so, Madam Chair, but I do kind of have another question about it too, and that is that, you know, this idea that, whether a treatment facility is an IMD should not be a factor in making placements. I mean, I guess I understand that on one level, but, you know, if there's a significant difference in cost, and two treatment facilities could meet the person's need, I don't know why we would, in law, say that we couldn't use that as a factor. You know, I mean, if the treatment needs are met. I mean, obviously, we don't want to have people going somewhere that's not appropriate for them just because it's cheaper. I mean, I think we probably all agree with that, but what this language seems to say is that even if two things were equal, we wouldn't be able to say on the basis of cost that they should go one place or the other.
Mr. Walsh.
Madam Chair and Representative Liebling, the three placement authorities in Minnesota are health plans and tribes and counties. In statute, they as placing authorities, they get to decide what is cost-effective and what is appropriate. So this bill in no way takes away from them the ability to decide what is cost-effective or what is appropriate. And so it will still be based on those two criteria.
Representative Liebling.
Thank you, Madam Chair. Well, okay, that's good to know. I don't know if that's actually in conflict with this language then, but I guess I'd like to hear from DHS a little bit about that because, you know, if you say that this IMD designation is not, cannot be a factor, shall not be a factor in making placements, I don't know, maybe that still leaves it open that if something's more costly than something else for whatever reason, maybe they still have that authority. I mean, can you address that?
Welcome to the committee. If you could introduce yourself.
Thank you, Madam Chair. Brian Zervis, I'm the Deputy Director of the Alcohol and Drug Abuse Division at the Department of Human Services. Madam Chair, Representative Liebling, I think that the question I heard you ask is whether or not current practice, if the IMD determination, a program's IMD designation can be used as a determining factor to place or not.
Representative Liebling.
Well, no, thank you, Madam Chair. No, because what the bill is doing, the bill is taking away, it's saying that the treatment facility designation as an IMD shall not be a factor in making placements. So apparently right now it is, because it doesn't get the federal match otherwise.
Mr. Service.
Madam Chair, Representative Liebling, the bill language would clarify and codify the current practice that IMD status is not to be used as a determining, or used in the determination of whether or not to place someone.
Representative Liebling.
Oh, okay. Madam Chair, thank you. Well, that is clarifying, so we already don't do it. Okay, and then I think the other piece I wanted you to address, even though this isn't the Finance Committee, I assume that, you know, I mean, there's going to be some cost, and can you just sort of give us maybe you could talk us through just a little bit again about how this financing piece works? I found that really confusing.
And can you repeat your last name?
Yeah, it's Zerbis.
Zerbis,
Yeah,
excuse me.
Zeirbes.
Mr. Zerbis.
Thank you, Madam Chair. Representative Liebling, to go back to the previous question about the funding and the county share, non-county share, it's dependent on the recipient's medical assistance status and the program's IMD designation or not. So there's a grid that sort of lays out if someone is let's say for example, an adult in current law, an adult without children in a non-IMD, there's 100% federal financial coverage, so there's no cost to the state and county. For an adult with children or families with children going into a non-IMD program, that the federal financial participation is 50%, the state's is 35%, and then the county is 15%. If an MA eligible individual is placed into an IMD, an Institute for Mental Disease, there's no federal financial participation. So that's where the state and county share. The county share is 22.95%, and the state share is 77.05%. And so what the bill language would outline is that instead of the 22.95% county share to the county, that would be 15% across the board. So whether a program is an IMD or is designated as an IMD or not would sort of balance the field from the county's point of view or the placing authority's point of view.
Okay.
Representative Liebling.
Thank you, Madam Chair, and I won't be labored anymore. Thank you, that was helpful. And Representative Baker, maybe when this gets to finance, if you could give us that little grid visually, I think that would be really helpful, because thinking of it that way is really helpful. Thank you.
Representative Baker.
Thank you, Madam Chair. I think, Representative Liebling, you ask a very good question. Because of the formulas, and they're so different when it's single or a family, 15% with the county here, and it's a fiscal note I'm also looking forward to. So we'll have that at finance when it goes there, because it's a number that I certainly want to know. This is, again, as they mentioned, this is a bridge. We hope to get on the waiver programs, we get this cleaned up. It should not be a long-term thing. We need to make sure that all the facilities now that are being used as an IMD or a non-IMD are still going to be used just like they were before. We want this to be seamless, and so that's why we need the legislature's help. We'll have that ready.
Thank you for that, Representative Baker. Members, any other questions? Okay, not seeing any. Thank you so much to the testifiers for being here.
Thanks for sticking around.
So Representative Baker
Thank you.
renews his motion that House File 3026 be recommended to be re-referred to the Committee on Health and Human Services Finance. All those in favor, say aye. Aye. Those opposed, no. The motion prevails. Thank you, Representative Baker. And members, thank you so much, and thank you to the audience. Apologize for keeping you into the evening on a very snowy evening. So truly apologize, but I hope everybody drives safely, and we will see you next week for our next regularly scheduled meeting. We are adjourned.